I am honored to be here in sharing with you this journey in the orthopedic field. I will do my best not to let you sleep. I'm sure that my talk has been strategically and purposely placed at this time so you can better sleep, but I will try not to allow you to do that. So the topic is a little bit challenging because this argument is really huge. And I have divided my presentation in different key points. So first of all, the definition of the problem. I will talk about a little bit on bone, cartilage, tendon, and ligaments, and I call these elements Cinderella for bioengineering now, because the main interest has been pointed to bone and cartilage, and I will draw some conclusions, very short conclusions. So the problem is clear. In our surgery, we do need bone, we do need to replace cartilage, we need to replace and repair tendon, and we do have a huge amount of muscle lesions, not only in the traumatology, but also in the sport medicine field. And I am really interested in that also. So let's start with the bone. We are facing more and more large bone defects. And the main cause for these bone defects, bone osteolysis, is a failure of the hip and knee prosthesis. So the bone regeneration in a large amount may be beyond the potential for self-healing. And trauma is another cause, and infection, tumor resection. You see the aseptic loosening around implants or skeletal abnormalities. And these are two examples. This is a leg with a wound and a bone loss due to a gunshot. And we have been using a cadaver tibia at the place of the pristine one. And on your right, there is a bone loss in a already revised total hip replacement. And you see the hip is dislocated, the cup up there is broken, and there is no bone around the stem. And that's a in vivo situation. You see here, maybe there is a pointer. There's no pointer, but you see here. Thank you. You see here, after the removal of the cup, there is a huge metallosis due to the wear of the metal of the cup. And removing all those membranes, we're going to find a huge bone loss, a huge cavity to be filled. And the revision surgery is increasing in number. And the destruction of the acetabular and femoral bone is really a challenge. What we have now is the impassion grafting technique, the bone impassion grafting, where we use morcellized bone graft. That's the femoral head from the bone bank, and we impact all these small pieces of bone to recreate the walls. But this is a dead bone, and on that dead bone we implant another cup. So the solution is good, but this bone can be reabsorbed if there is not become a vital bone later on. So bone owns the intrinsic skill for regeneration in response to the injury, and it's important to underline that it's a unique tissue of the bone because we don't have a scar tissue. We have new bone, remodeling for the weight bearing, but it's a completely new bone. There are a lot of cases where the bone regeneration can be impaired. So in the tibial fracture, almost up to 13% of those fractures can evolve in a non-union or a delayed union. And to have a bone healing, we need a stable mechanical environment. We do need the osteoconductive scaffold, which is already the two fragments of the fracture. We do need the growth factors, and they are coming on that side. We do need osteogenic cells. In case of bone loss, we have an area where the bone has disappeared. So we need also a new vascularity, we need to treat this chamber without bone that we call now biological chamber. So we need some membranes, and that's a new field in the traumatology. Membranes could be bioreabsorbable or non-reabsorbable, acting as a barrier to prevent soft tissue invasion and to form a chamber or the guidance of the bone regeneration process. And this is a technique we use now. It's a masculate technique. We use a periosteum. This is a bone loss. We fill this empty space with bone cement, and we try to respect the periosteum inside. And the periosteum is a very active biological membrane because it's highly vascularized, has a skill of secretion of a combination of growth factors, important for bone regeneration. And from the practical viewpoint, after a while, some weeks, we remove the bone cement, and we have a very good membrane, and we can put other elements inside. So the recipe is to put growth factor, is to put bone grafting, and to stabilize the fracture. And with this technique, we have very good results. Not always can be used, this technique. So we do need membranes, and they can be bioreabsorbable, not reabsorbable, or this kind of novel membrane, the alginate membrane, biopolymer, nanohydroxyapatite polyamide, whatsoever. And all these kind of material, they do have advantages and disadvantages. In the bioabsorbable, they can reabsorb too early. In the synthetic membrane, they can induce host tissue response as, above all, a foreign body reaction during the healing. And the non-absorbable, they maybe need a second surgical procedure for the removal, and they are more prone to secondary infection. So we have good and bad, and the decision-making of which one of using that is a difficult task also for us. So we do an ideal membrane, which does not exist. Should be biocompatible, with the capacity or the skill of not allowing the cells to invade the site of the bone fracture. They should be space-making. They should be able to integrate in the tissue. They should not cost too much, and this is another big problem. And they should have different membrane porosity, because the porosity, as we'll see later, is very important to allow the vascular ingrowth from the surrounding soft tissues. So researching that, we should have a membrane with a different microtopography in thickness, porosity, and perforation size. They should be able to prevent the bone graft absorption. They should be able to carry on some additional growth factor we may want to introduce and add in that biological chamber. And at this point, we should talk about the osteoconductive scaffold, because in that membrane, in that chamber, we should also add some different scaffold. And there is a huge amount of research work and also clinical work on that. This is another situation, how to fill this loss of bone stock. We have also, I was speaking about before the muscular procedure. We can make and apply the distraction osteogenesis and bone transportation. So we can make an osteotomy up here and pull this piece of bone, docking that bone to this side. And on the shoulder of this moving piece of bone, which is alive, new bone recreates. But we do need an external fixation. So it's a frame holding the fragments together. So it's much better, would be much easier to fill this gap with an autologous bone grafting, adding bone marrow aspirate, or we can use allografts, as I show you in the very first slides with that tibia coming from a cadaver. We can use bone substitute. We can add growth factor, but that's the problem with growth factor, that they should find living cells. Otherwise, if we add the growth factor in a dead tissue, that means nothing. And we should recreate a new membrane around the bone, because that's very important for the bone healing. So how to fill this lost bone stock? Autograft, from the iliac crest. That's a traditional bone bank we have and we carry in our own body. And the amount of bone there is limited, and the harvesting is painful. The morbidity is high, and the amount of bone is, above all, is limited. So we can use allograft to avoid the donor side morbidity. It's relatively easy to obtain and manage with the bone bank we have now. But of course, we have the risk of transmitting infection and sometimes of immunological rejections. And because they are or gamma radiated or freeze drying, if you combine the two treatments to have a very sterile product, the mechanical properties of this material and the osteoinductive, osteoconductive, and osteogenic properties can be very much decreased. So again, advantages and disadvantages. Again, membrane, bone graft. So inside the membrane, we would like to have an ideal bone graft substitute. We should be osteoconductive, osteoinductive, osteogenetic, similar strength to that of the bone, and this does not exist, with no potential for transmission of diseases, biocompatible, bioabsorbable, no provocation of osteoresponse, readily available, manageable, and cost-effective. And this is another very tricky point concerning the graft substitutes and the bone substitute. Just to remind you that the osteoconductivity is a scaffold which has the skill of being colonized and to support the ingrowth of new bone cells and the sprouting vessels inside. Osteoinductivity, that's a self-property, self-ability of the graft to promote the bone formation. Osteogenicity is related to the presence of bone-forming cells within the bone graft. And really, we are working on that. The pore size is important because if we have such a synthetic material, that makes a huge difference if I use this one instead of that one, because small pore tend to become filled with more avascular tissue. So it's they call for fibrotic tissues. Increase of pore may result in decreased mechanical properties. So we need around between 150, 500 micron in size, and pores in excess of 100 microns are required for penetration of highly newly vascularized connective tissue to be transformed in bone. And I'm going to present some of our investigation we have done. We have been looking to the 3 different scaffolds. This is bioabsorbable, and this is a trabecular titanium scaffold, which is very interesting because we do use this kind of material on a routine basis in our total hip replacement. And so I've been very much attracted by this because it's porous, and it can be built up. I will show you how it is produced. And compared to these 2 reabsorbable materials, this type of materials showed better behavior in terms of cell proliferation on the surface. And trabecular titanium, it is a metal, it's titanium, but the porosity is controlled, and it is produced with an electron beam melting of titanium powder. This is how a hip cap, the cap for the hip replacement is built. The factory is here in Sicily, but it's time consuming because in one night procedure we can have 20 caps like that. And if you increase the pore size, and you can do that only you acting on the software, you increase the elasticity. Of course, it's a metal. So what we are aiming to, and I will show some other papers on this investigation we have done, we are a little bit concerned of implanting big pieces of metal instead of a bone. But in terms of producing cells on that surface, producing extracellular matrix, we can eliminate the cells, and this material can be recognized as a self material by the patient. So we are working on that. Before that, we can use also demineralized bone matrix. This is produced by cadaver bone. There is bank selling this kind of material. Can be used alone or in combination with other material. It comes off the shelf with granules, strips, putty, gel, freeze-dried powder, very expensive. And there are no level 1 studies in humans. There is a lack of clinical scientific evidence in large bone defects of a really of the usefulness of that. It may show a lower osteoinductive capacity compared to the autologous bone graft obtained from the iliac crest. And the concentration of bone morphogenetic protein 2 and 7, those very important for bone healing, is very questionable because the variability is very high. Let's go very quickly through other products we can have purchase on the market. The tricalcium phosphate, hydroxyapatite ceramic, very hard. I don't like. They do not reabsorb very well, and they are very much cost effective because you see that's in dollars is $9 per gram compared to the $86 per gram of cancellous bone allograft material. So we can use this material in many different ways. But osteoinduction and substitution is lesser than autograft or allograft. So it's a sort of filling material of the defects. Same thing for the calcium phosphate. They do not reabsorb, so they stay as a foreign body. And the long-term results on the long-term destiny of that is not well known. The bioactive glasses are very interesting, but you see the resorption is very variable. They do have osteoconductive properties, on very small osteoinductive property. They come in microsphere, fibers, and porous implant. They are not very much used in our clinical practice. So the final end, none of these bone substitute offers a biomechanical strength similar to that of the cortical bone. None of them has the biological properties we are looking for, and so they are not suitable to be grafted at the place of cortical bone defects without additional support. That's the reason why I'm so interested in that trabecular titanium, because we can realize whatever shape and dimension we want, and if we will be able to let the cells of the patient grow on that, we can have a very I will not say cheap, but reasonably expensive product to be used. In the future, we can use silicon, we can use this kind of titanium, but the trabecular titanium is not one solid block piece of titanium. It's a powder melted and built up in a three-dimensional porotic structure. Tantalum as well is very much used in orthopedic surgery with very good bioactivity, biocompatibility, and ingrowth properties. And all these materials, they show the ability of incorporating mesenchymal bone stem cells on the surface. And this is something we are doing now because using adipose-derived stem cells from the patient we operate, we let them grow on this trabecular titanium scaffold, and this scaffold, the trabecular titanium, show the ability to be osteoinductive without any specific use of grown or conditioning medium, and we have just submitted this paper. We can increase the amount of cell growth on the scaffold. We can use vibration. This is another paper we published last year. And we can use magnetic fields. And this opens another chapter in our armamentarium for the bone healing. And we have been using the pulse electromagnetic fields. These are the two solenoids and the waves produced by the solenoids with the South2 cells on the polyurethane and many other different materials like hydroxyapatite. And the pulse electromagnetic fields is something we can use in the lab to improve and increase the cell growth and the cell differentiation on the different scaffold. We must remember that the bone has bioelectric potentials, and when we have a fracture, also the healing process goes through electric processes. So we can induce a modification using the solenoids to improve the quality of the bone healing. So we can use membranes, we can use scaffold, we can add different substances inside, making our own recipe, and we can influence the destiny of that with the solenoid and the pulse electromagnetic field. Or we can do this in the lab and make new things to be implanted at the place of the lacking bone. And we can have two different ways of using the pulse electromagnetic field, the capacitive way or the inductive way. So this capacitive, we apply a solenoid, and the pulse electromagnetic fields are coming from the solenoids into the body. An inductive method, we use microcurrents, and the pulse electromagnetic fields, they are created inside the body. But both ways, they are able to increase the synthesis and the production of TGF-beta by the osteocytes, and they can induce the calcium metabolism inside the cells. So they are really useful for that. So they are also able, according to this paper, to upregulate some genes controlling the bone formation and downregulate other genes controlling the bone reabsorption. So they have several clinical applications. Fracture at risk of delayed union, osteotomies, vertebral fractures, osteonecrosis, painful prosthesis, and the implant osseointegration. And they do work as a medication. So if you give some drug to the patient, the drug has effect. So if you look at that, the normalized callus is very much depending on the true stimulation if compared to a sham stimulation. All these papers are available in literature, and they're very interesting because they really witness the importance of using the pulse magnetic field. So that's after the overview on the bone. Let's go to the cartilage. And the cartilage has had a huge interest in the research, because the cartilage is a tissue non-vascularized and without any ability to repair. It's really very much important in the function of the joint, but it's not vascularized and it doesn't heal. And the only healing we can hope to have in a damaged joint is a sort of a fibrocartilage, which does not work as a pristine cartilage. The current option, by the way, in the knee, this is an arthroscopic view of the knee, and this one as well. In the small lesions, we can use the debridement of the joint, so to shave with particular instruments in arthroscopy the cartilage, like we have done here, or using the microfracture with these tips with this instrument. We can break the subchondral bone, let the marrow flowing out, and without weight bearing for 8 weeks, we have been able to demonstrate that a better fibrocartilage can grow. Or we can use a mosaic plasty, you see here. We can take pieces, cylinders of bone and cartilage from another place of the same knee, so we damage another place to save the weight-bearing areas of the condyle, and like a mosaic, we can replace and make a new surface. In larger lesion, we can use autologous chondrocyte implantation alone or on scaffold, again the scaffold, or we can unload the joint with an osteotomy to unload this area. So we will decrease the amount of load on the cartilage and the bone there, and we will decrease the pain, but we will not reproduce the cartilage. Or we can go straight forward at the joint replacement, metal and plastic instead of bone and cartilage. Again, also here we have 4 cardinal points. We do need osteochondral conductive scaffold, inductive signals, precursor cells, and the stable fixation. And this is a very tricky point, because our purpose in orthopedic surgery now is not to have only the cartilage, but we do need new bone. So it's almost a new organ, because we need the bone and we need the cartilage on that bone. So we need something mimicking the three-dimensional architecture of the extracellular matrix. So it's much more difficult than the simple bone. That's the reason why I'm more interested in bone than in cartilage, because it's much easier. And we have natural materials, synthetic materials, and ceramics, with advantages and disadvantages. The synthetic materials, like the reabsorbable one, they can cause degradation reaction into the body. So sometimes I have patients with a lot of wear and bone lysis due to the degradation byproducts of this material, or for a particular reaction to this material. So it's not easy to decide what to use. So again, we need the cartilage and we need the subchondral bone. So we may use type 1 collagen hydroxyapatite, which carries the mechanical stiffness and the cartilage on that. And this is very difficult. This is something available on the market. This is a very specialized and highly technologically produced membrane produced here in Italy by Finceramica. And this membrane, this scaffold, want to reproduce the stiffness of the bone down here, and a scaffolding up there softer to accept the cartilage and the new chondrocytes inside. I've been using some of them. The clinical results are not as good as expected, but they will try to improve this material. The negative side of this is a huge cost of that. So it costs more than a true prosthesis of metal and plastic. And again, also here we do need osteochondral inductive signals, different molecules, but how to control their release. Again, this is something related with the growth factor injection, so popular now for everything, from hair growth to the osteoarthritic degeneration of the joint and so on. But we inject a huge amount of growth factor altogether, so we don't know yet which one will be the best, which one will start, which one we need second and third to promote the healing of the tissue. What we do from the practical point of view is to mix the growth factor with scaffold precursor during fabrication. And the property of the scaffold for the cartilage, you should be able to regulate the release by diffusion. This is very much related with the name of your society, I think. We do need osteoinductive signals, and there are a bunch of researchers working on the micromagnetic fields to carry on the nanoparticles or the growth factor or whatever marked with bodies affected by the magnetic field from outside. But there are limitations. The magnets cannot be implantable and the scaffold cannot be magnetic. So again, here in the cartilage, and just to underline what I told you before, that in the cartilage recreation, regeneration, we should consider also the bone. This is a paper I published on the Journal of Orthopedic Research 4 years ago, and I've done a mosaicplasty, so I put a cylinder of bone and cartilage in the sheep, and this is the results with the pulse electromagnetic fields, and here the results with the sham stimulation of the sheep. So the scaffold, that's the autologous transplant, but we need something more. And in that case, the pulse electromagnetic fields have been very effective. The cells is the same thing as in the bone. We can use marrostromal cells, synovial membrane, adipose stem cells, umbilical cord, blood, with pro and contras, advantages and disadvantages. But still, we are very far away from the recreation of a true cartilage. And the problem of the bone, the problem of fixation, how can fix this scaffold, this construct into the bone inside? We can do by press fit, we can use fibrin glue, we can suture, we can use reabsorbable pin fixation, we can use the butyl 2 chanoacrylate, we can use magnetic fields. And all these fields deserve to be explored. And the very final section of my presentation are tendon ligaments. Ligaments is another huge market. 200,000 ACL, anterior cruciate ligament reconstruction, only in the USA. We do almost 200 only in my department per year. Rotator cuff repairs. Look at the numbers. So it's a huge market. It's a huge market from the, for the investigation, from the research point of view, but also for the money, because it's really a huge market for economy. Because you know, something substituting the ligaments and bone is worth to be considered very much by the businessman. The ligament, we can use autograft. That's a golden standard. If you break your ACL, I will take your bone patellar bone or the hamstring tendons, and I will replace your ACL. That's what we do in our soccer player or in any athletes. We can use allografts, avoiding the donor side morbidity. So we use cadaver tendons. But there is, even if very small, the risk of a disease transmission, and they have a poorer mechanical quality. But, you know, in a middle-aged, between brackets, soccer player, 35, 38, 40 years still playing, that could be the solution. Or this one could be the solution. But the only one working and available on the market now is this, the Lars ACL substitution, because all of these have failed with a huge problem on the bone, and for the generation of particulate matter responsible abrasion, wear, and bone lysis. So there is still a lot of things to do, a lot of investigation to do on the ligament. And again here, the role of growth factor, for me, my personal opinion, they are overrated and overused. The tendon scaffold. The tendon scaffold, you see, if you look at the literature, the tendon scaffold, there is a lot of interest. But the main problem of the tendon is very similar to that of the cartilage. We can replace a piece of tendon, but if we need to put the tendon inside the bone and let something grows inside to capture the insertion of the tendon, that's the main problem, because we still have a lot to do on the bone phase for the tendon-bone interface. So let's go to the conclusion, otherwise I will get you really bored. Only 2 slides. Now the orthopedic surgery is mostly like this. So this is my generation. That's what I do every day. Hip replacement, knee revision, hip revision. And these are huge scaffold, not of trabecular titanium, of tantalum, replacing the bone. You see the outline, the shape of this scaffold. And they are able to hold the bone ingrowth. They are able to stabilize the new plastic and metal I place and we place as orthopedic surgeons when we have to revise. So this is something that we do every day. But our interest should be really focused on how to have better material, better solution for that. Our purpose, and I think also your task, is to be able to replace this disease that were femoral condyle, not as a single tissue, not as a bone or a cartilage, but everything together in order to be able to get back. But I think we are far away from the possibility of recreating an organ. So still we have to concentrate on the tissue engineering and make and improve our experience on the different tissue we are dealing with every day. Thank you very much.
Thank you, Professor Benazzo, for your huge, interesting presentation in which many aspects of orthopedic surgery were underlined. Now the discussion is open. Please, are there any questions? Please, Professor Cohn.
Okay, thank you for your interesting presentation. And you talked about mesenchymal stem cells So, do you think this is a kind of personalized self-therapy is a good opportunity, or at least there should be a good opportunity in the future?
Yes, not considering the cost, but just considering the possibility of doing that. I think that if we find a good scaffold, and the ideal scaffold is not available at the moment, but if we find a good scaffold, and we are able to get the cells from the patient and let them grow and produce extracellular matrix, then we can eliminate the cells. So we don't need a cell factory or the immediate transportation of what we have done, the culture we have done in laboratory in the surgical field. And so we can store what is being prepared for that particular patient. We can have a construct recognized as self by the patient and providing the scaffolding for weight bearing, but also for cell growth. That's a very simple task we have, simple from the theoretical point of view, but difficult to realize.
Thank you.
Please, Professor McNeil.
Hi, congratulations on lovely work. And if I follow on from that question and answer, you were suggesting that you would use the patient's own cells to make a scaffold in the laboratory and then get rid of the cells. Why not use donor cells that have been banked by a tissue bank as a source of cells to make the scaffold with the ECM and then get rid of the cells? That way you would cut out all of the delay of taking weeks to make matrix from autologous cells.
You are perfectly right, yes. I was just discussing what we are doing now as a research investigation.
Oh, indeed.
And we are still far from the practical application of that. But your ideas, of course, that's the other way of considering that.
I know the tissue bankers throughout Europe right now are aware that they're using autologous bone marrow cells or fat-derived cells because they'll get them through the regulators. But the future really relies in allogeneic cells that could be banked, and that way treat a whole lot of patients. But we need to proceed stepwise.
Yes, but still we need a scaffold. And we need a scaffold, and so that's another research branch because we have to research the good scaffold for that specific situation because your femur is different from mine. And the load is different from in your femur than on my femur. So we need to increase our knowledge on the not only the material where the scaffold is made from, but also the shape or how to adapt the scaffold into the bone. And still we have to grow, let the cell grows on that. I think that we do need some extracellular matrix on that because the neoangiogenesis, so the formation of new vessels, as we saw that the crude material, any kind of material, is not good for the new vessels. If the material, any kind of material, is already coated by an extracellular matrix, that's a situation more friendly for the neoangiogenesis. Do you agree with that?
Absolutely.
Yes.
Yeah.
Are there any questions?
My curiosity is that if actually in the clinical practice, to choose the material or the approach to repair some bone defect, you can consider some pathologic situation with the patient, for example, osteoporosis or some different condition. You have the condition to choose different approach, different material.
Of course, I reviewed in my presentation a different solution because there is not only one solution good for every one of us, for everybody. So we have to adopt the solution where we are experiencing, because we cannot invent day by day the different solution. We have to adopt that particular solution for that particular situation, because you know, in the field of hip revision, the bone loss, ideally you have a cavity, a bigger cavity, but you have a cavity. So you can also fill with a mixture of scaffold, metallic scaffold, just to decrease the amount of bone you need, or bone with a supporting cap around in the boundaries, in the periphery of the acetabulum. So we have different solutions for that. And if you have a tumor in your tibia and I remove the entire tibia, and what can I do to replace? I can use a fibula, vascularized fibula, and just replace. But the difference in size, that means that you're going to have a very high probability of breaking the fibula because it's not big enough. So you need something to increase the strength of that piece of bone or whatever you want to place inside to let you walk and not stay on crutches for 2 years. So that's a different situation for every one of us, and we should be able to adopt the correct solution to afford the problem, the specific problem. That's the reason why the orthopedic field is so huge, and it becomes bigger and bigger every day, because if we stay only on the hip replacement, on knee replacement, and we don't care about the failures, or we don't care about the bone loss, or we don't care about the complication, okay, that's an easy life. But if you want to take care of the spectrum of the diseases of the patient from osteoarthritis, and there are means of decreasing the speed of worsening of osteoarthritis, and then that's the moment of the moment of the total hip or total joint, total leg or total shoulder replacement. But there is a whole spectrum of possible complication or downsides that you have to take care of.
Are there other questions? I have a curiosity. If I understand well, the electromagnetic stimulation, it is possible outside the body, yes, and inside the body. But what mean it for performance and for the patients? There is a different application outside or inside?
Yeah, as a matter of fact, the inside the body stimulation is almost only the radio frequency to decrease the pain in neuropathic pain. All the rest, it can be applied from the outside. So inductive or capacitive stimulation, there are small electrodes for the induction and the big solenoids or solenoids for the...
But outside the body, other forces like shock-wave or ultrasound are used? Of
course, yes. There are. Yes, we have done some experiments on very low intensity ultrasounds. Yes. That is cause almost a sort of vibration, so it's almost the same thing. What you mentioned also, ultrasound, the shockwave therapy. Yes. Yeah, that's another way of addressing the problem of the non-union, because they break the membranes, they can cause microbleeding and start again all the process of healing. I have no experience on that, because I think that the overall results, long-term results, are not as good as the surgical procedures.
Surgical approach is the best in your opinion?
Well, I'm a surgeon, so
yes. Thank you.
Thank you
Again, Professor Benazzo.